So CCGs came into existence in April 2013. Prior to that, we had PCTs, primary care trusts, who virtually did everything on behalf of the public in terms of commission and buying services. CCG locally is made up of 55 practices. We operate out of 3 localities, the north and west, the south and east locality, inner city and east. And all these localities have individual practice members who attend monthly meetings with the locality, so that there's a flow of information through the system from the patient through to the localities, through to the governing board of the CCG. We have, obviously, locally the area team, public health, the health wellbeing board, the clerk, the HSN, and a number of other organisations who we've alluded to in the video, and who form a complex picture. I think over the last 18 months, it is beginning to become clearer as to what each part of the system needs to do in order to provide a better health service for our community. You may ask, what were the drivers for this change? And I think there was a stated aim to bring about services out of hospital, closer to patients, to provide patients with, especially those with complex needs, a more holistic and integrated service. There's a drive to modernise general practice. General practice has had a very similar model for the last 50 years, probably, or more. And it's a very diverse service. We have 56 corner shops, 55 now in Bristol. Nationwide, there are thousands of GPs doing things all in slightly different ways. And that makes things very difficult for the NHS, especially acute hospitals who are trying to serve that area. The quality of the service, general practice, came under scrutiny. And also the support to the out-of-hospital care. Up until now, really, general practice, though obviously is mindful of what the local hospital is doing, doesn't really see itself as an organisation that comes together as a whole to support the local hospital. And things particularly like facilitated discharge from hospital and admission avoidance where appropriate. The change was also stimulated by the mounting financial crisis. I think that we should be honest about that. The NHS faces huge financial risks in the next 20 years, an ageing population, complex needs, and the ability to do more and more, but also which costs a lot of money. This is not to say that we should be doing things on the cheap, and far from it. The argument goes that if patients with complex needs are managed in the community close to their home in a more holistic, integrated way, the care will be better, of higher quality. It's what the patient wants, but also potentially might be cheaper. Another strong driver was also the greater health and social care integration. And as David's mentioned, I think we can see that with the creation of the health and wellbeing boards. So far, I would say health and wellbeing boards around the country have been mixed, but the potential is huge. You've got the coming together of local commissioners for health. You have the local council and their buying power around social care. And we have the potential to no longer have a gap, a barrier between patients, between their health need and social care need. As we know, these things are very arbitrary. 20 years ago, many of the people who are now in nursing care homes for which they pay for, or the council pays for, were in long-stay hospital beds. If we are to manage our elderly and our people with complex needs and dementia well in the community, we need to look at their social care needs alongside their healthcare needs. There was also a voice for better patient and public involvement, the personalisation care and the co-creation of services. And GPs were thought to be more in tune with their patients' needs and well placed to develop these more bespoke services, and perhaps balancing the power of the acute services. So 18 months on, how does it feel? Well, there's been some notable successes, I think. There are things we've done I don't think would have happened under PCTs. We've recommissioned mental health services in a collaborative approach, strongly influenced by service users, carers, primary care and Bristol City Council. We have an innovative model which is entirely different to what was there before. And throughout the whole process, it has been driven by the needs of service users. We have new community services such as the Rose Clinic. This is a reversal of female genital mutilation in general practice. It's the first of its kind in the country. And though it's a very small service, it's a very bespoke and very important service. There's been a much clearer focus on quality in our relationship with the hospital services. We have monthly meetings with our local trusts, and the focus on quality of care for the patients has been a real marker of the last year, 18 months. GPs are beginning to work together for the first time. We've never seen this before, beginning to design services to support patients in the community, to assist early discharge, mission avoidance and for the better handling of community care together alongside their secondary care colleagues. We have innovative IT schemes, including development of a community-wide shared patient record. One of the biggest drivers for integration in the NHS, I believe, is the ability to share information in real time. We have wonderful GP records, we have hospital records, we have social care records, we have mental health records, but all the time patients fall between the gaps. And one of the biggest reasons for falling between the gaps is because the inability to read something at 2 o'clock in the morning that somebody else did somewhere else in the health service at 2 a.m. the previous day. With this new system, which we are beginning to develop, I think we have the opportunity to put that right. Hospital doctors and GPs are talking to each other again about clinical problems and issues in the way they haven't done so for the last 20 years in my experience. However, we are approaching winter with the system under pressure. All over the country, emergency services and departments are struggling to meet the 4-hour target. Waiting times are under pressure. And in many parts of the country, GP recruitment of nurses and doctors is becoming a real problem. I know that elderly care consultants are real hard to come by, and if we are to have a service that meets the needs of the patient, these clinicians are really important to us. We also have a general election in 6 months, and the potential threat to yet another reorganisation. The NHS has been reorganised itself since 1974, and who's to say any of the other pre-organisations wouldn't have done anything better than we have today, but one thing's for sure, we need to stop doing that and to give us time to bed these things down and to do some work. There are many challenges. However, I do remain absolutely passionate that Clinical Commission, with all its potential, bringing managers and clinicians together across the primary secondary care divide and help design services with patients and carers will reap benefits for local people. Thank you, David.